Thank you, Hampton. I'm Sally Webb. It's my pleasure today to introduce one of our pediatric critical care faculty, Whitney Marvin, who joined us back in 2016. She went from one coast to the other, and Whitney did her pediatric residency and critical care fellowship at Rady Children's in San Diego. I forgot to ask you how to say this. Are you a Nevadadan, or how do you say that? A Nevadan. She's a Nevadan. No. Nevadan. Nevadan. And she grew up in Reno and went to medical school there. So Whitney has been a wonderful addition to our faculty. She has already won accolades and awards with her passion for education from both emergency medicine residents that rotate through the PICU and from you all, the pediatric residents. And I have really learned something from Whitney, and I'm continually impressed, and she serves as a role model, I think, to all of us for her commitment to talking with families and listening to patients and being involved with very complex, medically fragile patients in the PICU and doing a wonderful job with taking care of that population. And I think as I was listening to Hampton, there are a lot of similarities. His summary slide isn't up here, but we're going to learn from Whitney, really a hot topic in the critical care field now. And a lot of what you're going to talk about with sort of post-ICU patient and family emotional distress and maybe even physical issues, a lot of that's going to involve prevention from those of us who work in the ICU. So we'll have a focus on prevention to try and help ameliorate a lot of these effects that are just now coming out in the critical care literature. If you go to meetings, this is hot topic for both adult and pediatric care. So without any further hesitation, welcome Whitney.
Thank you. That was perfect. I don't think I could have planned that any better. The Nevada is nonstop. I'm like, Nevada. Everyone's like, right, yeah, Nevada. And I'm like, okay, we're just going to keep going. So today I'm going to talk about life after the ICU. So it's this interesting paradigm shift. We're interviewing right now, and we kind of talk about right out of the fellowship, what's your favorite topic? Everyone's always like, multi-organ failure, severe sepsis. And now 2 years later, I'm talking about what we do affects families and how, this has become really my new passion. So, and what is post-intensive care syndrome? I have no disclosures. We're going to talk a little bit about post-intensive care syndrome today, understand the implications of this on patients and our families, and identify some strategies at ameliorating PICS. So I want to walk you through a few patient stories to explain why this has become such a passion of mine. This first picture is of Allie. Allie was born very premature, had a long stay in the NICU, and subsequently the PICU on a ventilator with a tracheostomy. She had a twin brother who died during the first few weeks of her life in the NICU. Adea was adopted from Ethiopia, had some mild motor delays, and presented to us after a cardiac arrest and development of severe rhabdo. Cheyenne was a previously healthy teenager who developed influenza myocarditis, necessitating ECMO support due to her poor cardiac function. So a little history. Since critical care began over 50 years ago, there's been tremendous advances allowing us to save more lives. Although mortality has declined, survivors experience new and persistent impairments. There's even thought that in the pediatric critical care world over the last couple decades, we've really exchanged mortality for morbidity in our patients. So now there's this shift to optimize survivor and caregiver outcomes as we acknowledge that the post-ICU course may be equally or even more as important as the ICU course itself. So what are we going to do about this? Our Society of Critical Care Medicine held 2 stakeholder conferences in 2010 and 2012 for the adults that identified the impact of ICU stays on patients. So for example, they found that 50% of adults with ARDS had not returned to full work a year after discharge, and less than 10% of patients that were on mechanical ventilation for 4 days were completely independent a year later. During these conferences that were made up of critical care experts, physical, occupational therapists, palliative care, long-term care facility representatives, and patients and their families, they coined the term post-intensive care syndrome, or PICS, and with the goal to further identify risk factors for it and ways to mitigate its impact. So why is it such a problem? So typically for a patient that's got severe critical illness, they're sedated, mechanically ventilated, which is a vicious cycle. So overall, they end up overall immobilized, which can lead to more weakness and delirium, and sometimes more sedation to counteract the delirium. And you can see how this can result in pretty significant cognitive and functional impairments. So what exactly is PICS? I'm going to discuss PICS as it was initially described in adults. So the definition is a new or worsening impairment of physical, cognitive, or mental health arising after persistent or after hospitalization for critical illness. Mental health mainly focuses on depression, anxiety, PTSD, and sleep disturbances, including problems falling or staying asleep, as well as nightmares. These symptoms can last from months to years. Studies have shown that 8 to 50% of patients have symptoms of depression, 23 to 48% have symptoms of anxiety, and 10 to 50% have symptoms of PTSD. The current known risk factors for mental health disability after an ICU course are being female gender, having a lower educational level, and a pre-existing disability, or the use of sedation and analgesia. Cognitive impairment refers to problems around memory, attention, problem-solving, organizing, and working on complex tasks. After leaving the ICU, 30 to 80% of adults may have these issues. Many improve during their first year after discharge from the hospital, but some never fully recover. 25% of those with ARDS even have some type of cognitive impairment 6 years later. This can often feel the most disabling, since cognitive dysfunction is usually what will affect a patient's ability to return to work. Previously, this was thought to mostly occur in the elderly, but this has been proven untrue, and some of the biggest deficits are actually noted in prior higher functioning individuals, since their deficit gap is really the greatest. The main identifiable risk factors for cognitive impairment are the duration of delirium in the ICU, acute brain dysfunction, including stroke or alcoholism, hypoxia from ARDS or cardiac arrest, hypotension from severe sepsis or trauma, glucose dysregulation, prolonged mechanical ventilation, severe sepsis, use of renal replacement therapy, or prior cognitive impairment. Physical impairment. ICU-acquired weakness is the main physical impairment that develops during an ICU stay. It's incredibly common and occurs in up to 80% of patients on ventilators more than 4 days, and up to 75% of patients with sepsis and 50% of those who are in the ICU for at least a week. Patients who develop this ICU-acquired weakness may take more than a year to recover fully, and many never return to their prior baseline. This weakness can make the activities of daily living difficult, including grooming, dressing, feeding, or even walking. Current identified risk factors are being ventilated for more than a week, sepsis, multi-organ failure, or requiring deep sedation. So Mara et al. Just published the largest epidemiologic study of PICS to date in adults. It was a prospective cohort study that was nested within 2 different studies, the eye bringing to light the risk factors of incidence of neuropsychological dysfunction in ICU survivors, and the MIND ICU, which was in disabled veterans, or in veterans, not disabled prior. The investigators examined the frequency and determinants of physical disability, depression, and cognition in critically ill survivors from 5 hospitals. In-person assessments were made at 3 and 12 months. They measured cognition, depression, and disability using a neuropsychological inventory, the Beck Depression Inventory, and the CATS activities of daily living. They really wanted to focus on what was new, not necessarily what was worse, so they actually excluded all patients with prior cognitive impairment or disability. They ended up selecting 531 survivors who were 18 years or older and treated for respiratory failure or shock in a medical surgical ICU. 125 patients died with true or lost to follow-up before the first 3-month evaluation. But overall, they had 384 patients that underwent the 3-month and 334 patients that underwent the 12-month assessments, so had great cohort retention. Overall, the investigators confirmed that the majority of survivors incur PICS. Specifically, new PICS was present in 64% at 3 months and 56% of survivors at 12 months. When new impairment was identified, it was often to one domain, as only 19 and 6% of survivors had 2 or 3 impairments at 3 months. The most common new impairment was cognitive, with 38% having it at 3 months and 33% at 12 months. Depression was present in at least 1/3 of survivors at both 3 and 12, and disability only in about 26% of survivors at 3 months. But in general, a new impairment that was present at 3 months persisted. One positive out of this study is good news to trainees. The best positive protective predictive value was more years of education was associated with a greater risk chance of being PICS-free at 3 or 12 months. They also attempted to evaluate some modifiable risk factors for PICS, but none were identified in this study, although just since then there has been kind of more data that's been evaluated that did show that there are some other ones that are some other modifiable risk factors. They just didn't identify any. So circling back to our patients, both Cheyenne and Adea had a significant number of risk factors for PICS. Cheyenne's female required significant amounts of sedation, was hypoxic, hypotensive, required multiple rounds of mechanical ventilation and dialysis due to her multi-organ failure. Adea is also female, had a pre-existing, although minor disability, required sedation, and had subsequent issues with delirium. She presented after cardiac arrest with hypoxic insult as well as some glucose dysregulation, prolonged mechanical ventilation, and multi-system organ failure. So shifting focus to the family, and as many know, critical illness can really truly be a family crisis. Families may feel worried and confused and even stop tending to their own health. Long-term consequences in families consist of psychological, physical, and social problems. So it's important to note that PICS family or PICS-F can occur in families of survivors and non-survivors and may persist for years. The most common problems experienced include sleep deprivation, anxiety, depression, complicated grief, and PTSD. Around 10 to 75% of patients, families suffer from anxiety. Up to 42% have symptoms of PTSD, which will be up to 50% or more if the patient's had a child or the patient died. 1/3 of families are taking medications for anxiety or depression at discharge. If the patient doesn't survive, the family may suffer from the feelings of loss or prolonged or complicated grief, and I'm going to talk about that a little bit more in a second. Potential physical and social consequences include weakness and exacerbation of their own health problems. Family dynamics may also be altered as caregiver roles can be reversed, or family members may need to take time off work to care for the patients or themselves, which on top of medical costs can put the family's financial security at risk. The main risk factors for post-intensive care syndrome in families is being female gender, the younger age of the relative or the patient, poor communication between the staff, being in a decision-making role, a lower educational level, being unmarried, and having a family member that was close to death. So you're all probably thinking, this is pediatric grand rounds. Are we ever going to talk about the kids? So after the 2012 ICCM Stakeholders Conference, we've recognized that PICS framework may have implications for the pediatric intensive care population, as well as another multidisciplinary group met and developed the PICS-P framework. So the pediatric framework was published in April of this year. Studies in PICS and pediatric ICU survivors are incredibly limited, but data is accumulating and many children do develop significant long-lasting morbidities after those observed, similar to those observed in adults. Now the core focus of the PICS-P framework is on the child, which is obviously very broad, includes infants, children, adolescents. The heterogeneity of our population encompasses a wide spectrum of physiologic conditions occurring in children of varying social, cognitive, and developmental capacities. There's also a large number of children that have chronic illnesses and developmental disabilities at baseline. So a child's critical illness occurs at a time of tremendous growth along a dynamic developmental trajectory. Thus, new functional and cognitive impairments may affect a cascade of developmental milestones, school performance, and social interactions, placing a child at risk for a multitude of problems later in life. Conversely, the child's capacity for growth may be a source of resilience that provide a platform for recovery after critical illness. The psychosocial and family effects are also different, and children's social life is primarily organized around the family and school. So over 25 studies have found a broad range of physical sequelae in children, including respiratory dysfunction, pain, diminished sensation, poor mobility, impaired self-care, and feeding issues. Children with baseline normal function often experience greater functional decline, but have quicker recovery than those with baseline impairment. Among children with severe sepsis, for example, 18% exhibited poor function 28 days after admission, and 17% of those with a month-long ICU stay had at least moderate disability. Long-term studies are limited, but some children develop new dysfunction even years after discharge. 9% of previously healthy children continue to require help for daily care 3 years after severe critical illness. The main risk factors have been identified for pediatric physical disability are the presence of a baseline disability, admission for trauma, neurologic or oncologic disorder, as well as cardiac arrest, longer PICU length of stay, age less than 1, or severity of illness. One major problem in the literature in comparing studies is the multitude of assessments. For physical disabilities alone, these 25 studies used 11 different functional assessments for their patients. So lower IQ and moderate to severe deficits in attention and memory are common and adversely affect academic performance compared to healthy controls. Baseline cognitive status is very difficult to determine retrospectively, especially in children, and many studies that assess cognition are focused on one diagnosis, like meningitis, for example. There are multiple performance categories that estimate global cognitive function and change over the ICU stay. These studies have estimated cognitive problems in anywhere from 3 to 73% of survivors. Cognitive impairments after the PICU discharge may evolve over time. Among 186 PICU survivors seen in a follow-up clinic, PCPC, which is the Pediatric Cerebral Performance category, scores were normal at discharge for only 25% of healthy children with an unplanned PICU admission. By 3 months, scores improved and normalized for 77%, but declined further in 21. Thus, the new cognitive impairment is often evident at discharge, and it may worsen over time. Risk factors for cognitive dysfunction are admission for trauma, injury or poisoning, neurologic problem, cancer, invasive mechanical ventilation, ECMO, and also longer length of stay. Emotional health can lead to many different issues, from psychiatric diagnoses to sleep disorders and behavioral issues. PTSD continues to be common even in the pediatric population. It's associated with delusional memories and length of sedation, illness severity, emergency admission, sepsis, and exposure to invasive procedures. 9 studies of PTSD after the pediatric ICU have shown a diagnosis in 5 to 28% of children with symptoms in up to 62% of patients. A study by Alzenal in 2015 reviewed 88 children 5 months after discharge. They found 20% at risk for general psychiatric disorder, 34% at risk for PTSD, and noted 38% had fatigue. It had symptoms of a fatigue disorder, and 80% of them had sleep difficulties, with frequent awakenings, sleep anxiety, and bedtime resistance, and overall just sleep difficulty. Another study noted that after TBI, 47% of children had sleep fatigue, as well as health which was well above healthy peers. Depression is estimated to occur in up to 12% of patients and children, had emotional conduct hyperactivity and social difficulties more than their peers. Parents often describe patients that were in the ICU as having poor self-esteem, less emotional well-being, increased anxiety, and negative behavioral changes. School-age children report delusional memories, hallucinations, medical fears, anxiety, and changes in friendships and their sense of self. There was 3 qualitative studies that were also published that children related that they experienced a lot of confusion and uncertainty surrounding the hospitalization, awkwardness in talking about the experience, and a gap between their former self and new circumstances. This a possible new dependency on caregivers, and a subsequent feeling of isolation and abandonment from their peers. Risk factors for long-term problems include a history of traumatic life events, prior psych problems, poor social support, and negative memories from the PICU. The effects of parents on pediatric patients is different due to the unique nature of the parent-child relationship, which is often referred to as the inseparable dyad. Sibling relationships can also change these dynamics, and they may themselves experience stress, loss of parental attention, and increased responsibilities related to the child's critical illness with an unknown long-term impact. Critical illness can significantly impact the family's social functioning, and including their reintegration with peers, their social capital, and the possible economic impact of unemployment. So a little bit more about PICS and specifically pediatric parents. There are many different psychological sequelae that manifest. 1/3 have an acute stress disorder. Up to 84% of pediatric parents report post-traumatic symptoms, and 10 to 21% meet criteria for PTSD. Up to 50% have anxiety, and 30% have depression. A recent study by Bronner assessed PTSD in parents 3 months after a PICU admission. PTSD includes symptoms in 3 clusters: intrusions, avoidance, and hyperarousal. They found that out of the 250 eligible families, they had 144 participated. 21 mothers, which is 15%, and 10 fathers, 9%, met the full psychiatric diagnosis of PTSD. In 6 families, both the parents had it, and there was a significant correlation between symptoms in both parents. They didn't find any medical risk factors that could be distinguished in these families. Currently, there's a paucity of longitudinal epidemiologic studies that consider the child's pre-PICU status in describing the nature and duration of the child's post-PICU recovery. So I'm not going to go into this too much, other than we know that there's obviously a multitude of recovery trajectories that vary according to the individual and the child. So one way to decrease prevalence in PICs in families is to prevent or minimize the risk factors. This may be done in part through bundle adherence, early mobilization, and attempting to avoid deep sedation and delirium. There's increasing support on the benefit of ICU follow-up clinics, as well as the use of psychologists during the ICU stay and patient and family diaries. So what are these potentially modifiable risk factors? Here I've listed them in purple and include the use of sedation and analgesia, duration of delirium in the ICU, acute brain dysfunction, hypoxia, hypotension, glucose dysregulation, prolonged mechanical ventilation, use of renal replacement therapy. Now I acknowledge that many of these are very difficult to modify and may be present on admission and unchangeable in many circumstances. I also want to clarify I'm not advocating for no sedation or analgesia. That would cause an uprising in the ICU for sure. And if you're hoping that I'm about to go into strategies to avoid renal replacement therapy or talk about glucose dysregulation, that's really not the goal of this talk either. So what is the ABCDEF bundle? So this is a part of this bigger project in our critical care group called the ICU Liberation Project. And it starts, A is for assessing, treating, and managing pain. B is for both spontaneous awakening and breathing trials. C is for choice of sedation and analgesia. This includes the avoidance of neuromuscular blockers and steroids when possible. There's also good evidence about the correlation of benzodiazepines and delirium, so when able, we recommend avoiding those. Delirium monitoring and management includes attempting to normalize a day-night wake cycle, avoiding medications that may increase delirium risks or exacerbate them, and promoting sleep, not just sedation. E is for early mobility and exercise, which I'm going to talk a little bit more about in a second, and F is for family engagement. In adults, these bundle adherence has been shown to actually decrease days on mechanical ventilation, decrease delirium by up to 50%, increase mobilization, and actually increase hospital survival. Other goals to strive for should be to provide a healing and compassionate environment, which is presumed to decrease anxiety and delirium, promote sleep, and demonstrate understanding and respect for both the needs of the patient and the family. Even things like attending to room temperature and lighting, decreasing noise and false alarms as much as able, and assuring the patient has whatever sensory aids they need, like glasses, can be beneficial to their physical and emotional well-being. So early mobility. So this concept is not new, and there was actually an editorial in JAMA decades ago that described early rising after surgery and included a more rapid return to normal strength and activity and a better outlook and morale of the patient. And as early as 1944, a controlled trial of early mobilization after major surgery found less surgical and organ-specific complications. Studies have found that patients can safely tolerate mobility very early in the ICU, even when on mechanical ventilation with invasive catheters and on continuous IV infusions. Activities may range from passive to active range of motion and neuromuscular electrical stimulation to ambulation. It's been shown to lower ICU and hospital lengths of stay and decrease cost of care in adults. It can also increase strength, improve functional status, decrease delirium, depression, and anxiety. We still don't know how it changes the short-term and long-term trajectory of pediatric patients, though. We've not yet determined the optimal timing, dose, duration of these interventions, how much is too much or too often, and is there a threshold where risk may outweigh benefit. There was a great study recently by Coelho Garcia about early mobilization in critically ill children, a review in that study. It demonstrated the following key findings. Early may be defined as mobilization within 48 to 72 hours of PICU admission. There is established neurodevelopmentally appropriate levels defined for critically ill children. And mobility-based physical rehab is safe and feasible, although, like I said, the efficacy is still yet to be determined. In '98, there was an editorial written, and I just love this quote, by an adult critical care physician named Thomas Petty, who compared his rounds in the ICU with those at the start of his career. He said, "But what I see these days are paralyzed, sedated, lying without motion, appearing to be dead, except for the monitors that tell me otherwise." So ICU follow-up clinics. The United Kingdom offers these to almost 30% of their adult ICU survivors. Although the data is still early in the early phases about the effects of these. Patient selection for each clinic is variable. Some ICU clinics offer them to all their ICU follow-up patients, and some of them offer them only to the sickest patients, those with ARDS, sepsis, delirium, or prolonged mechanical ventilation. There's a lot of different ways that these clinics are offered, sometimes just from a nurse follow-up clinic to a multidisciplinary clinic with many different specialists. So early results have shown that survivors value the continuity in care, including being all monitored, receiving referrals to specialists, and receiving reassurance from the ICU staff, whom they consider to be experts in their condition. A survey by Colville et al. Looked at pediatric patients from pediatric ICU, and they said that 2/3 of their patients said that they would have appreciated a follow-up clinic to discuss their child's ICU admission. The goal is really not to take over the primary care of the patients, but to refer out to specialists and then refer back to the primary care specialists when able. The Thrive Initiative is something else that was developed from the Society of Critical Care Medicine to share information about these clinics, and it actually just started in 2015 with 6 clinics and is broadening every year. These bottom 2 graphs are something that was published out of Vanderbilt's medical ICU follow-up clinic and how they use pharmacists in their clinic to identify and treat medication-related problems, as well as implement some safety procedures. So of their study, they had 56 patients, and they said all had at least one pharmacy intervention in their clinic. 22 had medication stopped, 18 had new medication started, and the pharmacist identified 9 patients with an adverse drug event, and 18 patients had an adverse drug event preventative measure instituted. So what about ICU diaries? These are actually widely used in Europe and are slowly taking hold in the US. Daily events are recorded by the healthcare staff and the patient's families. This is evidence for reducing PTSD and delirium and possibly anxiety and depression in adult patients and their caregivers, with PTSD prevalence reduced in as much as 50% through early diary use. When read by the patient after discharge, diaries can fill in memory gaps, replace false memories and delusions, and help them understand what happened to them. Pictures seem to be of substantial benefit, especially in pediatrics. Seeing themselves as patients in different situations has been reported to help them make sense of and deal with the feeling of unreality around their ICU admission. It's important to state the obvious that pictures can also be very powerful. We thus need more information on how to be able to introduce them in an age-appropriate way. The diary can actually be important to the entire family unit. Although intended primarily for the child, it seems parents and siblings may also benefit from reading it. It can be a catalyst for discussion for parents to discuss the PICU experience with their children, and may help them make it more meaningful and, if possible, a positive experience. Supporting mothers' coping processes after the child's PICU stay through a diary may also reduce stress and anxiety in the patient too. When psychologists are included early in the primary care team, they offer both patients and families support, counseling, and education or stress management and coping skills. Their involvement has been shown to cut the prevalence of anxiety, depression, and PTSD symptomatology in half in adult studies. One of the core ideas about decreasing PICS family is through family-centered care. Part of that encompasses quality communication. When communication is perceived as good by the family, it decreases adverse psychological outcomes. So making sure the family has frequent and understandable updates about the patient's condition and prognosis, asking and incorporating the family's description of the patient's values and wishes into shared decision-making, and promoting family presence and participation in care is of utmost importance. Involving caseworkers and social workers early can help ensure families have the skills needed to care for the patient at home. And if a psychologist or peer support group is available, these can further support open communication. In fact, mothers of critically ill children who perceived they spoke about their feelings during the admission had lower PTSD symptoms at follow-up. It's also important to assure the family has information on post-intensive care syndrome so that they feel less alone and isolated if their routine has not returned to their prior normal. Lastly, though, but this should be first and foremost, assuring the family is participating in self-care. So I briefly want to talk about taking care of parents after the death of a child, since PICS family can still affect this group of caregivers. There's a great article written by Tessie October, who presented at Grand Rounds here a couple years ago. It was published this fall, and I'd recommend it to everyone, because sometimes I don't think we think enough or know what to do with a family after the patient died. So I'll be using the term parent, but this really does refer to any primary caregivers, not just the mother and father. The grief experienced by parents, though, is more intense and prolonged than grief following the death of other family members. Population-based studies have demonstrated an increased risk of mortality of parents, especially after trauma-related deaths. There's also higher for mothers and those of minor children. Parents may have a general decline in physical health with greater healthcare utilization, greater number of sick days from work, and more sleep problems after the death. They have higher risk for disorders such as complicated grief, anxiety, depression, and post-traumatic stress disorder, including higher suicidal ideations and suicide. Complicated grief consists of persistent separation and distress and chronic stress response and includes involving loss of a significant other, symptoms of separation distress, cognitive, emotional, or behavioral symptoms, duration of 6 months or longer, and impairment in functioning, and it cannot be better explained by another diagnosis. Complicated grief is estimated to occur in about 10 to 20% of those of bereaved individuals, but in 40% of patients, of pediatric patients, will have it at 6 months, and in 60% parents will have it at 6 months, and 40% will continue to have these symptoms at 18 months after the death of a child. Marital disruption has also been reported in up to 8 times the population divorce rates and is more common among bereaved parents of a traumatic child. Financial stressors are also common. Parents have reported an average of 15 weeks of leave without pay, which leads to further life stressors such as poor quality of life, financial crises, and interpersonal conflicts. So good communication is still the key. There's a great table that lists positive communication behaviors noted by bereaved parents, including honest and frequent information, delivery of the data how the family wants it. Some families may not want every detail. Some may want only the bottom line, so take the time to ask the parents how they like communication to be delivered. Personal conflict with staff has been shown to have long-lasting positive effect. Personal contact, not conflict, with staff has been shown to have long-lasting positive effects on parents, and empathetic contact has been shown to decrease existential loneliness. Informal types of bereavement support, such as sympathy cards, letters, emails, phone cards, and attendance at memorials and funerals, are deeply appreciated by parents when provided by health professionals who have cared for their child. Formal follow-up meetings between a parent and their child's PICU physician or other care providers can also be offered and serve as a forum to provide parents additional medical information and emotional support, offer referrals, and present an opportunity to give feedback on their hospital experience. There's a pediatric critical care research network who developed a framework, which I included here, for conducting these parent-physician follow-up meetings after a child's death. The framework is not intended as a script, but rather a flexible guideline. So what's next? There's increasing concern that sedatives commonly used during our illness, critical illness, may be neurotoxic during periods of early brain development. This is a great ongoing study by Martha Curley, known as the Sedation, Strategy, and Cognitive Outcome After Critical Illness in Early Childhood, the Restore Cognition Study, which is a prospective cohort study designed to examine relationships between sedative exposure during pediatric critical illness and neurocognitive outcomes. They're assessing multiple domains of neurocognitive function 2.5 to 5 years post-discharge in patients who are 2 weeks to 8 years at the time of PICU admission, as well as evaluating healthy age-matched siblings. The goal is to increase understanding of the relationships between sedative exposure, critical illness, and long-term neurocognitive outcomes. So barriers, we often are working in silos. Critical care has historically been provided in isolation from primary care providers, and like many specialists, we seem to work in our own area. Discharge notes are often inadequate and focus on organ-specific issues with less focus on patients' actual functional impairments. There are important deficits in the primary care clinician's awareness and preparation to provide and coordinate care for survivors. But fortunately, pediatricians don't have a significant number of PICU survivors who experience significant morbidity. So they may also be unaware of all the problems that they may face and the possibility of PICS in the patient and their family. There are a multitude of assessment tools, so comparing studies can also be difficult. And PICS-P is still in its infancy, so research is ongoing. At this time, there's no proven therapies to reduce PICS, so we have to see if we are asking the right questions or even studying the right interventions. So moving forward, it's important to increase the awareness of this possible long-term consequences of intensive care among ICU survivors and their families. Awareness can decrease fear of the unknown, decrease feelings of being unique, or that something else is wrong with them, and alert them to the possible need of patient for follow-up assessments and referrals. There are also websites that have been developed on Wikipedia and through Johns Hopkins on PICS. There are several YouTube videos about patient experiences and a pamphlet on the SCCM website. I'd encourage any of you who are assessing a patient or a family who's had a significant ICU stay for symptoms of post-intensive care syndrome and to assure that they're appropriately plugged into whatever resources they may need. Also, ask the detailed questions. We had an older teenager male patient who was recently in the ICU for over a month. And when I called to check in, the mom kept telling me how fantastic he was doing. I asked specifically about his sleep. She said it was great. He was sleeping great, which was a surprise to me since he had so many issues when he was here. When I further questioned, she said, well, I mean, he is still sleeping with me, but he's sleeping great. So just asking those detailed questions to see really if they are doing as well as they're saying. So moving forward, the critical care community hopes to map out the natural history of post-intensive care syndrome and recovery after critical illness, and evaluating interventions to mitigate its impact for poor outcomes. Adults are also developing peer support groups like this one in the corner for survivors and their families, and are currently trying to assess their impact. So here's a list of websites for families and healthcare professionals about PICS. And so our patients, where are they now? So Allie's been admitted to the hospital many times since her initial discharge, but fortunately is growing and developing well. She's working on getting her trach out. Unfortunately, her parents have separated and have had symptoms of complicated grief after the loss of her brother. Adea has been in and out of the rehab, but continues to make gains each day. Her mom has become a huge advocate and learned a ton about her diagnosis. Her smile is contagious, and all her therapists say that they don't want her treatments to stop because how much of a joy she is to be around. Cheyenne had a 3-month hospital course and eventually went to rehab and was discharged home. After she was home, I contacted her about how recovery was going. She said very eloquently she was going through her own grieving process about her illness and her hospitalization. She wasn't really leaving the house and had little interest in seeing any of her friends. Cheyenne and her parents didn't trust their pediatrician anymore, despite acknowledging this was likely unreasonable, but nonetheless didn't have a provider to go to. After some continued encouragement, she established a new PCP, started counseling, and is now thriving. Her mom says she's walking with a new confidence she hasn't seen before. Cheyenne and her family will be joining a few of us in San Diego this February to an accept award that I nominated her for. She's receiving the only Pediatric ICU Hero Award given out at to a patient and a family and their care team for exemplary family support and multi-professional care. And I have to put these in. These are a few of my personal favorite picks. And the Astros, yeah, this is how we played baseball in that house. And yes, the Astros lost last night. So my husband was very quiet this morning. And I talk real fast.
That was great, Whitney. You had to choose 2 or 3 things that you'd like to do at our institution to help mitigate some of these effects afterwards. What out of all the direction things do you want?
I mean, I would like follow-up. You know, I think that that's our big thing. I think that a lot of these patients don't even go see their PCP, or if they go see their PCP, it's kind of like a checkbox, like, oh, you're in the hospital, you're doing okay. But I think establishing some sort of a follow-up clinic would be a goal of mine. Now, in whatever way, shape, or form that will look like, I'm not sure yet. But that would be, I think, the big thing that I think is going to end up showing a lot of importance. And
as you pointed out, I guess as we move forward to a shift in mentality and other medicine, either multiple providers, outpatient or hospital, trust is a big issue. And it takes time to get to know what people fear about. And we get focused on the monitors and the physiology and all that. Much easier to probe that.
yeah, you're absolutely right. And I think like the common theme about everything that I read was communication, 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 you know, like, you know, having a better rapport with families, understanding, you know, what their fears are, how they want communication to be delivered, you know, all of those things, good communication, good relationships are all protective against families at least having issues after the ICU stay.
think it's really, I think it's fantastic that we have some kind of follow-up with all people for a long day. I guess like, everybody has spent so much time over with families, you know, into them, and then they kind of go away unless you make the call and right, here's what's going on, very well mannered, and there's impact on. And I think a pediatrician, the occupational long week today, they come to the clinic, that would be pretty burdensome for that. All that material that they went. And I feel like having a step down kind of clinic where you say, hey, you're great, that would be great. You can't go back before that, but you have to fully go to the higher level of care. So I think I'm safe. I don't think I'm going to throw anybody in the bus, but I think there's no doubt. And what we're all pointing out is that the best scenario have some sort of fun time that actually and working on an example that figured out pretty out scale diagnosis. We now have 3% of the audience care. And I think you'll partnership here to and how you care beyond the and beyond our like to a true seamless way your education route.
Well, this was actually, and he's not here, so now I can throw him under the
That's
bus.
why
This was actually Conrad's fellowship project. Was like palliative care incorporated into ICU survivors and their transition. So, you know, people like nudging.
oh, well, that's squarely on my shoulder.
I was going to ask a question about your health, your fit. And as many would fail to change fear or something that doesn't mean that we think terrible and that by fear and approaching holistic way that will keep
I mean, I feel like that's how I have to present it to patients. You know, like we're gonna, you know, complex diagnoses. And I'm like, we're getting a protein, but it's not only endoblind, it's not only hospice.
and that's just too much energy. Glad we have
You know, it should be like everything. It's intended as like then we accept
we need to
that.
rebrand it. The other thing is, we have a nationally recognized crime victims center here on campus, and you talked about the frequency of PTSD and other psychiatric disorders. I think there's a role for inpatient psychologists to see these patients before they go home. We lost our psychiatric consult nurse-led team, but it would seem as though, because a lot of the data presented were diagnoses at follow-up, right? Yeah. Not necessarily in the hospital, but in transitioning out of the ICU up to the board, that would certainly be a role or involvement with our psychiatric.
Okay.
It's not. I mean, everybody's literally just picking time points too. I mean, in all the cities, you know, some are saying like we're going to do it at 3 months, some are doing it at 5 months, and some are doing it at 9 months. So people are just picking time. Some of the ICU follow-up clinics see them in a month, and so that's when they do their assessments. So it's nothing is. It's so unknown about like what is right, how, you know, what's the right tool, when is the right time. I don't think any of it's known. But take a time and start doing it. See. That's what everyone's saying. Thank you. Thank you.